Hi, welcome to APP to APP lectures. I'm Amy Tees. I'm a nurse practitioner with a special interest in headaches and concussions. I have an added qualification or certification in headache, and then a postmaster's degree in headache management. I've been doing neuro and headache for about 20 years now. I'm going to move on to our lecture, Concussion Treatment in 2023. There are a few disclosures to speak of. None of this influences our talk. And in fact, if anything, the biggest thing to note is that there is very few, if any, specific medications for treatment of concussion. And so we're going to be mainly speaking off-label here. These are our objectives. Obviously, we want to understand the different types of headaches, the different treatment options for common post-headache concussion, and how other therapies, non-medication therapies, may be helpful, as well as identifying some of the atypical symptoms where we would consider imaging or to consider other diagnoses. So this is the ICD-3 or International Criteria Headache Disorders 3 and post-traumatic headache definition. It is a moving definition, meaning that each year or two, we kind of discover more things of how to define concussion and how to come up with severity scales, basically. And I'm not going to get into all that, although I can if needed in the future. So the better way to define concussion may be related to mechanism, sports, falls, motor vehicle accident, blast injuries, etc. We have to talk about the underpathophysiology, the biomechanical processes that may have happened, and symptoms that are more practical, especially when it comes to research studies. So using these, a sports concussion, by definition, is a prolonged transient alteration in neuronal function due to a blow to the athlete's head and or body with transmission of force to the head, resulting in rotational or translational and lateral movement of the head, resulting in neurological symptoms that resolve sequentially over time. That's, again, a moving definition. And because this is about athletes and your patient may or may not be an athlete, we're just going to kind of extrapolate because most of the research was done on athletes. Obviously, headache is one of the first symptoms to present after a head injury, and it's often one of the most persistent and longer lasting symptoms, and may I add here, probably one of the most disabling as well. It's difficult to define. There's mild traumatic brain injury, mild traumatic or traumatic TBI. There's all kinds of different definitions or words you may hear, and in reality, it probably all means the same thing. Mechanism of injury can be argued as well, going back to that rotational injury, or lateral movement, or compression injury, etc. So treatment for those complicated headache symptoms is not often required, but it can be required. And certainly if there's a pre-existing headache disorder, it makes it much more likely for those headaches to have worsened after any type of head injury. So headache with concussion is based upon the phenotype of that type of pain. It's not an exclusive list, but this is some of the types of headaches you may see. So there's that delayed onset of acute headache related to the head injury. So you may see the headache in the days following or not even immediately. There's a tension type headache. There's obviously cervicogenic or cervical dystonia. All of these I'll get into in a moment. Migraine can be episodic or chronic. It may have been an episodic migraine before, and now status post-injury, that patient has become more chronic. There's the whole umbrella of trigeminal autonomic cephalgias, which are a multitude of different ones, and then hypnic headache, as well as intracranial hypotension. The most common is that chronic daily headache with migraine features or a migraine phenotype. And so that's what I'm going to spend a little bit more time on, but we'll get into that in a second. So common comorbidities with concussion is some of the psychiatric disorders that we often see even with migraine patients. There's sleep disorders that could have been prior to their head injury and then gets worse or exacerbated by their head injury. And then comorbidities may vary depending on their pre-existing condition and type of headache they had even prior to it. I'm not going to discuss all the associated symptoms with concussion, including balance issues, vertigo, somatic issues, cognitive, visual, all of that. I'm not going to get into all that. Basically, we're just going to talk about the headache portion of that treatment. So the most important thing is, obviously, if we've discussed this in other lectures, is evaluating for secondary headache causes, making sure we're not missing anything. So we wanted to make sure there's no cranial vascular disorder, there's no psychiatric headache, because sometimes that can be related to either somatic injuries or just even medication effect. There can be a non-vascular intracranial disorder, including tumors or changes in fluid. There can be substance abuse or substance abuse withdrawal headaches. Obviously, just disruption of homeostasis, so changing in metabolic function, endocrine function, even electrolytes or hydration. And then facial pain or headache attributed to something within the eyes, ears, nose, neck, etc. Intracranial hypertension and hypotension, and obviously we're going to focus a little bit more on the hypotension part, and then related to infection. So these are common headache triggers. So these to me are concerning if we see some of these, and some of them are less concerning. So physical exertion, so a headache brought on by physical exertion, whether that's sex or orgasm, whether that's bending forward, or especially if it's a thunderclap or immediate onset of type of headache. If it's improved or made worse by laying down, getting upright, etc. Stress can be a pretty common one, whether that's stimulation, light, noise, smells, etc. That's a little bit hard to discern in concussion, because obviously some of those patients may be having headache or having symptoms just from being overly stimulated, which then can set off a headache or it can set off other concussion symptoms. Sleep issues, which can be triggered by too much sleep or too little sleep. Environmental issues can also trigger headache. And then diet, that can vary by person. It's very hard to say which dietary trigger may have caused a headache or migraine. And then hormonal changes. Obviously, if they have a family history of headache or they've had similar headaches in the past, it makes you feel a little bit more comfortable treating it as that phenotype. I often ask the patient, even if I've been seeing them for years and years, is this headache or migraine different? Is there something new? Is there a change in character or a change in presentation? And if there isn't, I'm obviously much more comfortable treating it as the same type of headache or migraine that we might have been treating for a while. Our headache evaluation, I think we've gone over this in other lectures as well, but we're going to talk about that injury, severity, mechanism. Is there a loss of consciousness? Was there other injuries? Did surgery end up being required? What type of headache is it? Is there a certain placement? Is there a frequency? Does something make it better or worse? What are the associated symptoms that maybe bring it on or make it worse? Is there a previous headache disorder? Like I said, feeling more comfortable that this is a similar type of headache that that patient has had previously. Past medical history. What kind of social support is there for this patient? Are they pushing themselves to work or school or family because they can't rest when they need to? Are there sleep issues or psychiatric issues or even employment issues? There's a threat of being fired or not being able to provide for their family. History of headache disorder in the family. So again, we know that migraine tends to be very genetic. And so that again would make us a little bit more comfortable. There's risk factors, including previous history of head injury or previous history of headaches, as well as being female. Some of the testing we're going to go over a little bit and how we would think about doing that testing. And then you have to do a diagnosis and treatment, but with a comprehensive plan. And that may be involving physical therapists, that may be involving non-medication treatments, that may be involving visual therapy or cognitive therapy, in addition to all of this, depending on what some of their most bothersome symptoms as far as the concussion goes. Testing for headache, normally we think of a brain MRI with and without contrast. This is done to evaluate for CSF leak, because that can come up in the future. That can be done at your testing center. I happen to mention mine here, but they need to make sure to look for a CSF leak. So I'll write it in comments, or I'll write, C protocol, because it's a very specific protocol that they can look at, but it has to be done with contrast in order to evaluate that. And then obviously, depending on what we consider the mechanism of injury and maybe their symptoms, we might consider an MRI of the cervical spine as well. Headache types after concussion. This is again that ICD-3 criteria, so International Criteria Headache Disorders 3. This is our definition. You can see it's quite expansive. And so there's post-concussion syndrome or post-concussive symptoms. Can be when those symptoms of a mild traumatic brain injury last longer than expected after injury. Most of the time, we expect them to get better over time, not worse over time. And these symptoms can include headache as well as dizziness, concentration, memory, and they can last weeks to months or sometimes even longer. Although at that point, we generally kind of convert them into a chronic headache disorder. That persistent headache after head injury, so separate definition, has to begin or be reported to have begun within 7 days of the head injury or awareness of the injury. It's somewhat arbitrary because of that 7 days. So, I mean, if it was, 5 days or 10 days, you still might consider this diagnosis. Some data suggests that headache may begin even after a longer interval. And following that diagnostic criteria, the maximum interval time between the head injury and the headache onset should be 3 months, but you usually see it within a week. Again, you can presume that the headaches began if it's closer in time to when the head injury was, that it's likely attributed to the injury. Again, very busy slide. I'm sorry about this, but that is the, again, criteria for diagnosing these. So delayed onset, as you might imagine, you're going to go through some of the traumatic injury, Glasgow Coma Scale, loss of consciousness, amnesia testing, alterations of awareness, all of those things. And then talking about that headache developed between 7 days and 3 months after injury, kind of like we just discussed before. Delayed onset attributed again to moderate to severe injury is these same things, and then that it lasts for more than 3 months. Cervicogenic or cervical dystonia, so meaning arising from the neck. A cervicogenic headache is a disorder from the cervical spine, whether that's bony, disc, soft tissue, nerve, etc., usually, but not always, accompanied by headache pain. And so here's our criteria for that. Again, there should be imaging at some point to evaluate for some of those other causes to rule those out. And then the headache has to have developed in temporal relation to the onset. So again, in time relation to the onset of the cervical disorder and appearance of lesion. So again, it should match up with what we're seeing on imaging. The headache has significantly improved or resolved as we get that cervical disorder or lesion improved. Range of motion may be reduced. Headache is significantly made worse by provocative factors or maneuvers such as, pushing on the head or pulling on the head. And it has made improvement or completely abolished by blocking that particular nerve or that cervical structure. Cervical dystonia, switching gears, is a headache caused by dystonia, so overspasm of the neck muscles that may involve abnormal movements or posturing of the neck, or overspasm of the neck muscles, typically posteriorly. Neck and posterior head pain is some of the criteria. Cervicogenic dystonia is demonstrated by abnormal movements, so the patient may have a tremor, they may just be more comfortable in this position, or retrocollis or anterior collis, and the evidence of that causation is some of these below. So again, pain is related in the temporal relation to the onset of when the dystonia occurred. The pain occurred within a reasonable time after that. It significantly worsened as the dystonia got worse, and it's improved or resolved as the dystonia improves. There may be pain corresponding to different dystonic muscles and which one is spasming at the particular time. So non-pharmacological methods are obviously available. There's physical therapy, gentle manipulation, massage. There's non-steroidal anti-inflammatories and muscle relaxers. We may consider preventative migraine options depending on how that headache kind of turns out. There may be interventional treatment options, again, depending on the pathophysiology within the imaging. Is there something we can treat with a cervical epidural steroid block or a bundle medial branch block? Something like that. And often it's all of these things, right? It's all of these things to make the patient better. And cervical dystonia treatment is mainly muscle relaxers, physical therapy, and the non-pharmacological methods we talked about before. There is Onibot, so you can use Botox-like toxin in different dosing and in different injection sites depending on that patient's symptoms. And then obviously when more severe, we would consider deep brain stimulation. Switching gears now, we're going to talk about the common migraine phenotype. So again, here's the definition of migraine, and that is here with an aura. So that aura has to be a visual, sensory, speech or language, motor, brainstem, or retinal and those symptoms are fully reversible, typically occurring 15 minutes, although those symptoms can resolve within an hour prior to headache pain typically, or at least the headache pain starts in a short period after those symptoms. And then obviously the other migrainous symptoms. So at least two of the following characters. So that aura symptom spreads gradually over 5 minutes. 2 or more aura symptoms can occur at the same time. Each individual aura lasts anywhere from 5 minutes to 60. Average, I believe, is about 15. And at least one aura symptom is one-sided, and at least one aura symptom is positive. I know that sounds strange, but positive in a neurological issue is something added to ourselves. So whether that's seeing spots or whether that's having vertigo or dizziness, that's our self plus something, versus actually losing tone or losing function would be a negative neurological symptom. Migraine treatment is after we have resolved and made sure and evaluated that all the other possibilities are done. And so we would think of those abortive, and we all do this, right? We're all thinking of, when we're picking a medication, that person's history, that person's lifestyle, what their comorbidities are. You know, maybe they have middle of the night headache that hits them really fast, and we need to think about something that's going to be a little bit faster than an oral pill. And then deciding on whether or not that patient needs prophylactic treatment, so something daily or preventatively. I don't necessarily think of that as a numbers game. It doesn't have to be 15 migraines per month. It has to be more, how disabled are they from their migraines? Do they have something that's effective that they can use? Are they still missing 1 day of work each week or something like that? And then obviously, again, we're thinking about route of administration, their comorbidities, how's compliance issue? Is there a risk of pregnancy, or are they avoiding pregnancy? Is there a side effect profile that they would not tolerate? And this is all covered a little bit more in the migraine talk, so I'm not going to go into all of this. But obviously, we think of stacking therapy, often giving 2 medications at a little bit lower dose to have less side effects and better outcome by treating the migraine in 2 different ways. This is, again, has been reviewed in other lectures, I'm sure, but this is kind of a way to think about that history, the diagnostics, and some of the red flags. This was made up by David Dodick, who was a lecturer, who is a lecturer at American Headache Society, and he's also was a headache specialist at Mayo, although he's since left. So we're thinking about those systemic symptoms, whether they have weight loss, history of malignancy, they're immunocompromised, there could be an infection, neurological symptoms. Again, we're looking for those focal neurological symptoms when we're doing the exam, maybe confusion, is there tinnitus, is there something else that's abnormal on the exam? Obviously, a new onset after age 50 or in children, we're a little bit more concerned. And like we alluded to before, that thunderclap, that really quickly onset, which can be either brought on by nothing or by cough, sneezing, sex, orgasm, Valsalva, etc. Is there a positional quality? Is it better made flat versus being upright? Is there a prior history of headache? So whether that's trauma, infection, or like for us in Arizona, valley fever or cocci is very common. So we always have to kind of keep in mind that that could be a possibility. Pregnancy, again, is considered a concern because that's a little bit of a red flag. Obviously, there's different vasculature and all that kind of stuff. There's a new onset, meaning they've never had a history of headaches before, and progressive symptoms, meaning they're made worse each time we see them or each time they come in or describe a headache. This is a long, big, busy slide, but I don't think we have to cover all of it. Just know that there's a variety of abortive treatment options so that when the patient has pain, they can reach for nonsteroidal anti-inflammatories or COX-2 or triptans or DHE or combo therapy. I don't generally recommend combo therapy because those have 3 different chemicals. The patient has the potential of rebounding or having overuse from 3 different chemicals. And then, as you see on this list, there is not narcotics. There's been nothing that's been really shown that encourages me to use narcotics. Prophylactic options, I'm sure this has been covered, but tricyclic antidepressants, namely amitriptyline, SNRI, so venlafaxine, beta blockers. ARBs have also now been seen to have some benefit. They are not FDA approved yet, although we anticipate that. The 2 anti-epileptic medications for migraine that have been FDA approved are topiramate and Depakote. We talked about Anabot before, and then the CGRP preventable, so marunimab, galcanezumab, franizumab, atogepant, There's an IV one, and then there's another oral that you would do every other day. There's neuromodulation devices. Unfortunately, as much as I may want patients to be able to try those things, sometimes they're cost prohibitive as they're not covered by insurance. Now switching gears again to a different umbrella. So we're going to come away from the migraine and we're going to go on to the trigeminal autonomic cephalgias. So I'm sure some of you have heard of cluster headache. Those are those unilateral severe pain, usually orbital, supraorbital, temporal, or even retroorbital. Any combination of that, typically lasting for 15 to 180 minutes, occurring from every other day to even 8 times a day, often occurring more at night, often occurring more in men. Sometimes I'll hear patients say they have cluster headache, and I have to go back and say, no, that's a specific type of headache disorder. It doesn't mean that your headaches are clustering together. So sometimes that involves a little bit of teaching. Mainly, we want to know that all of these trigeminal autonomic cephalgias have some sort of autonomic symptom, something telling me that nerve is involved. And so that can be facial sweating, that can be rhinorrhea, congestion, scleral redness, all kinds of eyelid edema, restlessness, all types of things that you may see with that patient. And then the differences between these, and again, this is probably discussed in a different lecture, is that the paroxysmal hemicrania is unilateral pain, and these can last anywhere from 2 to 30 minutes. So the timing is different. And these patients may have them more often during the day, and they respond perfectly to endomethacin. So that's obviously something we would want to try if we're even considering one of these diagnoses. And then dropping down to the short lasting unilateral neuralgiform headache attack, so often called SUNCT. These attacks, again, moderate to severe, unilateral, lasting seconds to minutes. So the timing is the key here. That helps us make the diagnosis. And then the last one is hemicrania continua. So again, the unilateral, and that's a baseline of pain and then spikes periodically, baseline of pain spikes. And then we have this diagnosis of probable, meaning we haven't kind of figured out which subtype it is, but we're assuming it's this, and it's probably worthwhile to try endomethacin or to try treating that patient. Hypnic headache is actually one of my favorite headache disorders. So it kind of is related to a sleep disorder. Often we'll know, when we're falling asleep that we feel that little jerky. This is kind of that jerky myoclonic jerk, but in our brain while we're slipping from different stages. So typically occurs 15 minutes to 4 hours after, that's wrong, I'm sorry, it should say after sleeping, and it can occur on more than 10 days per month and for lasting more than 3 months. There's no autonomic symptoms, there's no migrainous type symptoms, or if there are, they're pretty mild, and you need to make sure you're screening for headache disorders in other types, as well as screening for sleep disorders, because that may be triggering or causing it or making it worse. Interestingly enough, it's treated with caffeine prior to bedtime. And then if obviously the patient can't fall asleep after having that, then they would use melatonin to help with that. And again, here we recommend high dose melatonin, not kind of the typical doses that you may see over the counter as a first time. Intracranial hypotension or a CSF leak. This is very important because we don't want to miss these in the patients, as they can get worse, and it can have a lot of comorbidities and associated symptoms that also can get worse over time. So this is a condition, as you might imagine, where there is an abnormally low pressure or volume of CSF within the skull due to a reduction of that CSF, which can be related to multiple different reasons or causes. We'll go through some of that. It's more common with certain comorbidities such as EDS or hypermobility or other connective spine or tissue disorders, spurs, herniated disc, previous head or spine surgery, cranial surgery, and then certain nerve root avulsions, or even if people are overtaking too much fluid during a LP or shunt or something like that. So there's a variety of different causes that we've identified, but the prevalence of that is harder to figure out. We don't actually fully understand how many patients are out there. It's probably more than we realize, and those patients may be misdiagnosed with another headache disorder. But if there's a postural history to any of the headaches, and there's a significant history of cervical motion or twisting, we need to keep this in the back of our mind. So symptoms can include, like we said, positional quality of the headache, although this can disappear over time, nausea, photophobia, dizziness, hearing changes. People will describe muffled hearing or tinnitus. And I want to pinpoint that the nausea, photophobia, and all that is hard because those patients may be pulling away from stimuli because of their concussion. And so it's a little bit difficult. Neck pain or stiffness, we often call this the coat hanger headache, meaning if you would imagine the top of the coat hanger goes across the occipital, and then the bottom of the coat hanger becomes across the trapezius or even down to the scapula, people will combine of pain and spasms in that area. It can be associated with memory issues or difficulty concentrating or visual issues. Again, that's hard because often concussion patients describe those symptoms as well. Treatment, as far as the easier treatments, is caffeine, fluids, time and rest in a flat position, not pillows, not elevated, at the most a 10-degree pillow. If there needs to be more aggressive treatment, there is an empiric blood patch where you don't know where the leak is, but ideally it's a high volume of blood you're putting back into the dura, and typically it has to be repeated, unfortunately, 40% of the time. If you end up having to repeat it, you would consider fibrin glue or even consider surgery. And I would recommend that if those patients don't get better after 1, 2, even 3 patches, that depending on your location, you might want to refer to a hypotension clinic around the country. So this is kind of coming back into summary. Obviously, we're going to take a very thorough history, including headache before the injury, that mechanism of action of how we got here. Is it different than their previous headaches, or is it just increased in severity or increased in frequency, but the symptoms are all the same? We're going to evaluate for those green flags versus red flags, and that might tell us that we're going to need further investigation, whether that be blood work, imaging, or just a more complicated history. Think about the comorbidities and treat those if you can. So whether that's depression, whether that's visual, whether that's sleep disorders, we're going to kind of evaluate for that and send them off to the appropriate area if needed. We're always going to recommend the toolbox approach. So thinking about all of our options for treatment, all of the varieties that we may have, thinking about that patient and their comorbidities, their ability to comply, side effects, interactions, all of the things we obviously always consider, and even thinking about the lifestyle, adjustments, like maybe they need to sleep a little bit more while they're recovering, or maybe they don't need to exercise as hard as they did before while they're recovering. And headache care and post-concussion care is comprehensive. It's that whole team approach that we talked about. There may be a concussion specialist as well as a headache specialist. There may be a neurologist as well as primary care. There may be physical therapy, visual therapy. The list goes on and on depending on what each individual patient needs over time.